Okay, going to get started. My only financial disclosure for this is the up-to-date K cards. So I think many of the principles that Alan has already gone over in his cases are some of the things that we'll talk in a more didactic way in talking about potassium disorders. So the key things that I wanted to talk about the relevant physiology as we go through this, just to remind us all about how K secretion in the distal nephron is regulated. We'll talk also about the renal and also the adrenal renin-angiotensin system and potassium homeostasis. And we'll talk as we go forward about hyper and hypokalemia and some of the diagnostic tests, the clinical consequences, and treatment. So the key thing that I think all of you are aware of is that extracellular fluid potassium is a tiny fraction of whole body potassium. So there's this tremendous interplay between mostly muscle potassium as a major reservoir of potassium, but also liver, red cells, and bone as reservoirs of potassium as well. And it's important to remember that balance between extracellular fluid potassium and muscle potassium is tightly regulated to keep potassium within a safe range. Most potassium is excreted by the kidney, but as we'll talk about, the colon and the GI tract does play a role in K secretion. This interplay between muscle potassium and serum potassium is regulated by various hormones and other factors. Insulin increases uptake by muscle. Beta-2 catecholamine receptors turn on uptake, whereas alpha catecholamine receptors tend to reduce uptake. Acidosis tends to reduce uptake by muscle, whereas alkalosis tends to increase it. So you'll have hyperkalemia in the setting of non-anti-GAP acidosis, and hypokalemia relatively due to an increase in uptake in alkalosis. Hyperosmolality doesn't so much change uptake, but it actually seems to cause an efflux of potassium from muscle. So if you give somebody hypertonic mannitol and so on and so forth, you may get hyperkalemia. So potassium, if you look at the nephron, is reabsorbed in bulk by the proximal tubule, but that's not really tightly regulated in terms of potassium homeostasis. There is transport in the thick ascending limb, and there's recycling of potassium through the thick limb and the collecting duct, and that is regulated. But the bulk of regulated potassium secretion occurs very early in the distal nephron in the connecting tubule. So the connecting tubule is that section between the distal convoluted tubule and the cortical collecting duct. And the capacity to secrete potassium and reabsorb sodium through ENaC is much, much, much greater in the connecting tubule. And we've realized that over the last decade or so. Much of the physiology used to be derived from cortical collecting duct because they're easier to perfuse. But we now know that the connecting tubule is where the business happens. In the setting of higher aldosterone levels, ENaC gets progressively recruited along the collecting duct, but again, it's mostly in the early CNT. And in the setting of K loss, you get an increase in reabsorption in the intermedullary collecting duct and outer medullary collecting duct, mostly through intercalated cells through the HK-ATPase, which actually doesn't have a huge amount of clinical relevance in terms of potassium disorders, but does play a big role in potassium reclamation. But again, in the same way that we talked about in hyponatremia, the principal cell being the sort of final common pathway, the principal cell really is sort of the final common pathway when it comes to potassium disorders and regulated K secretion. So the principal cells obviously have aquaporin 2 and aquaporin 3 and 4, but they also have the epithelial sodium channel, ENaC, that's sensitive to amiloride. Because there's no chloride transport in principal cells, the sodium reabsorption through ENaC generates a lumen-negative potential difference. This is different from the thick ascending limb where there's a lumen-positive potential difference that then drives paracellular sodium transport. Here, this lumen-negative potential difference drives K secretion through two major potassium channels. One is BK, the big potassium channel, and the other is ROMK, or the renal outer medullary K channel. And ROMK is really the constitutive secretory K channel of principal cells. So it's always there to some degree, unless it's regulated down. and it's the one that's turned on most of the time. In the setting of high flow, the BK channel is turned on, and the same with increase in intracellular calcium, the BK channel is turned on. If you knock out ROMK, or if you have Bartter syndrome where you don't have a functional ROMK, the K secretion is taken over by the BK channel. So there is some degree of functional redundancy. But really the major one is ROMK, the renal outermedullary K channel. ROMK, just by way of history, was actually cloned in our division by my mentor in the early 90s, Steve Hebert. So really it was one of the major sort of contributions to cell and renal physiology in the early 90s from the Brigham. However, it's not quite that simple. The collecting duct obviously is composed of many different cells, and the connecting tubule of many different cells. And the adjacent alpha intercalated cells also play a role in potassium excretion. The details aren't all that important. There is basolateral NAKCl transport that causes a basolateral uptake of K in intercalated cells. There is the HK ATPase that plays a role in reabsorption. And there is also apical BK channels and voltage-gated K channels in the intercalated cell. Point being that we think of the principal cell as being the only sort of player in distal potassium transport, but the alpha intercalated cells also play a role. Why is that clinically relevant? Well, if you take a rat and you put them on a milleride, so you block all of the principal cell K secretion, there is still K secretion that occurs. So there is a big chunk of potassium excretion by the distal nephron that doesn't go through principal cells, and it's mostly through intercalated cells. Another issue is this tight interrelationship between distal tubular flow, distal tubular sodium delivery, and the ability to secrete potassium. So if you look at animals that are on a high K diet where apical K channels are upregulated, so you have a higher capacity to secrete potassium versus a normal K diet or a low K diet, in all three settings, if you increase tubular flow, you increase K secretion. So there is this flow-dependent component of K secretion. Clearly in a hypovolemic patient where distal tubular fluid delivery goes down, that's partly why they can't excrete potassium. Much of that flow-dependent K secretion is probably through the BK channels. The other issue is this phenomenon of distal tubular sodium delivery being a key regulatory factor and limiting factor in K secretion. So again, if you look at animals that are on a high sodium intake versus on a low sodium intake, at any level of serum potassium, K excretion is blunted if in the sodium depleted animals because they can't excrete potassium. So what is that physiology? What underlies that? Well, the major issue is that if you don't deliver sodium to the collecting duct and connecting tubule and to principal cells, you can't generate that lumen negative potential difference, and then you can't excrete potassium. And again, this is extraordinarily helpful clinically. If you see somebody with a low urine sodium because they're hypovolemic and they're hyperkalemic, that's the mechanism for the hyperkalemia. In terms of passing your boards, there are easily 10 questions on the boards where they'll present you a hyperkalemic patient or an acidemic patient and say, give all this big long story, and then the key element is that urine sodium that's 18, and that'll be what is causing the defect in K secretion or acid secretion. We're not talking about it in this lecture, but adjacent to the principal cells are the alpha intercalated cells that secrete acid. They do that through an electrogenic HATPase, and that voltage, that lumen negative voltage, is required to keep that going. So that's what we talk about, the voltage sensitive defect in distal proton secretion. So again, a very common, easy question on the boards is to go back to this physiology and this issue of distal tubular sodium delivery with a low urine sodium and the ability to secrete K. The other clinically important issue, of course, is the level of circulating aldosterone. If you do an adrenalectomy in animals and then replace them with only 0.4 times the appropriate amount of aldosterone, your ability to excrete potassium is blunted. If you replete them with 5 times the level of normal level of circulating aldo, K secretion is exaggerated. So that suggests, aldosterone plays an extremely important role in K secretion. What we'll talk a little bit about is the fact that this aldo paradox, that it's very important in K secretion, but there is aldo-independent regulation of K secretion that's also very important. So again, thinking about that, aldosterone, think of it as sort of setting the stage for potassium excretion. So aldosterone turns on the NAK ATPase. It also turns on ENaC through multiple different mechanisms, many of which were discovered through the pathophysiology of Little syndrome. It doesn't really have that much direct effect on apical K channels. They're turned on by the relative amount of potassium and dietary potassium through signaling factors that are less well characterized, but include things like angiotensin II. So really, the K secretory capacity is not set up by aldo. It's that lumen negative potential difference that's turned on by aldosterone. In terms of causes of hyperkalemia, I won't go through these in great detail. I think you're all very familiar with them. Increased intake is a big issue, decreased renal excretion, intra to extracellular shifts. Remember that with metabolic acidemia, yes, you will get hyperkalemia, but you don't see it with anion gap acidosis. So if somebody with lactic acidosis is hyperkalemic, it's not because of the lactic acidosis directly. The hand waving is that you get K and lactate going into cells, and that is electroneutral and doesn't require that exit of K. And then finally, there are artifactual causes. If you look in the Brenner and Rector chapter, there's a long description of the various forms of artifactual hyperkalemia, including some of the genetic forms of pseudohyperkalemia. If we think of the renin-angiotensin system, at every step of that physiology, you can develop hyperkalemia due to drugs. So if you think of giving NSAIDs and COX-2 inhibitors, as we'll see, they blunt renin secretion. Aliskiren obviously is a renin inhibitor, and it affects the renin receptor. Beta blockers reduce renin secretion, and so do the calcineurin inhibitors like cyclosporin. ACE inhibitors, of course, reduce generation of angiotensin II, which in turn is blocked by angiotensin receptor blockers. If we think of aldosterone and the mineralocorticoid receptor, spironolactone and canrenone and eplerenone are inhibitors of the mineralocorticoid receptor. Remember drospirenone, it's a component of contraceptives, and it has a similar affinity for the mineralocorticoid as does spironolactone. So it has mineralocorticoid blocking effects that are equivalent to about 25 milligrams a day of spironolactone. So it's a component of some of the oral contraceptives such as Jazz and Jasmine. They're less popular now because they're associated with DVTs, but that also is something that is, I think, fair game for your boards to have that as one of the causes of hyperkalemia. Then when we get to the tubule, there are various different ENaC blockers. Obviously, amiloride, triamterene as well. Trimethoprim, of course, that's why Bactrim and the trimethoprim in Bactrim causes hyperkalemia, but again, can cause a renal tubular acidosis because of that voltage effect on the ENaC as well. Pentamidine also blocks ENaC as well. There's a drug available in Japan called nafamostat that inhibits a protease that activates ENaC. Proteases that are spilled into the urine in nephrotic syndrome, part of how they cause sodium retention is through activation of ENaC through the same mechanism. It's important when you see patients with hyperkalemia to take a dietary history. There are foods that are very high in contact. Dried figs are extremely high or very high, dried nuts and so on. I think the common ones that we see, though, are the ones that have a high content, such as tomatoes, potatoes, oranges, and other vegetables. The key take-home message, I think, with diet and potassium is it's rare that diet is the exclusive cause of hyperkalemia, but we all see patients with CKD who can't tolerate really a normal amount of potassium, and we need to look at what their foods are that we can restrict and allow for them to maintain normal potassium. Finally, I want to talk a little bit about hyporeninemic hypoaldosteronism. because I think this is really a very quantitatively important syndrome that we see a lot and probably don't always think about. These are patients that have low levels of circulating renin and low levels of circulating aldosterone. They have hyperkalemic acidosis about 50% of the time with a urine pH that is classically less than 5.5. They have hyperkalemia. They'll have a decreased plasma renin activity and decreased aldo, and a blunted response of these to stimuli such as furosemide, which inhibits the NAKCl cotransporter, and captopril. Commonly, we see this in elderly patients with reduced GFR, and we see it classically in diabetics. And the key issue, which I'll try to go through a little bit, is that they're often hypertensive with some clinical increase in their extracellular fluid volume. There are many different causes and many different mechanisms. Diabetic nephropathy is a big cause. You see it in acute GN. It's classically seen in post-strep GN that patients will have hyporeninemic hypoaldosteronism that resolves as the GN gets better. In parentheses, I put tubular interstitial nephropathies like sickle cell disease. This is mostly tubular damage, so it's actually the tubule itself that is damaged, not so much a decrease in circulating renin and aldo. It's seen very classically with NSAIDs and COX-2 inhibitors, but also with cyclosporin and tacrolimus. And there's some hereditary causes such as pseudohypoaldosteronism or Gordon syndrome. So I'm going to go through some of these clinical scenarios because I think they all illustrate interesting aspects of the physiology of potassium excretion in hyperkalemia. So we have to break, to make an omelet, we have to break a few eggs. So we're going to talk a little bit about physiology and anatomy. And just to remind us all that the macula densa is that component of the tubule where it comes back to the vascular pole of the glomerulus and is stuck onto the glomerulus. And that portion of the tubule has these specialized tall columnar cells called macula densa cells. They have the same transport makeup as thick ascending limb cells, and they have the NAKCl cotransporter that we'll see is a big component of the tubular sensing for both renin release, but also tubular glomerular feedback, which we won't talk about today. You then have the extraglomerular mesangium between the vascular pole, and then you have the granular cells in the afferent arteriole that are the cells that secrete renin from the kidney. So this whole component we talk about as the juxtaglomerular apparatus that includes that afferent arteriole, the extraglomerular mesangium, and the adherent macula densa. One of the interesting things that came out of Vanderbilt University now more than 20 years ago was that COX-2 was expressed in the macula densa in an inducible fashion. It was sort of thought that COX-2 was only inducible in immune cells, so this was a bit of a surprise. Well, it turns out if you look at the macula densa that has the NAKCl cotransporter, that's the sensor for tubular chloride, if you increase tubular chloride, you increase the level of arachidonic acid through PLA2, and then COX-2 generates local prostaglandins that then activate locally the prostaglandin receptor in juxtaglomerular cells, turn on pKa and cyclic AMP, and increase renin secretion. So again, this little syncytium of these adherent adjacent cells, COX-2 plays a big role in that signaling between the macula densa and the juxtaglomerular apparatus. So why do we care about this clinically? Well, this mechanism is to a large part why we see hyporeninemic hypoaldosteronism in response to NSAIDs and in response to COX-2 inhibitors. So one of the classic case reports of hyporeninemic hypoaldosteronism due to NSAIDs was a woman with CKD due to lupus nephritis who had a very high potassium when she was first seen on Indocin or indomethacin. She had a low plasma renin and a low aldosterone, and she had low urinary aldo and lowish urinary prostaglandins on the NSAID. As she stopped her NSAID, urinary prostaglandins increased, and as that happened, potassium came down because plasma renin came up and plasma aldosterone came down over a matter of days. So this is really the mechanism for hyporeninemic hypoaldosteronism in response to NSAIDs. and it's one of the many different mechanisms whereby NSAIDs cause hyperkalemia. However, the important issue is to remember that we think of renin generated by the kidney turning on angiotensin II, and that turns on adrenal aldosterone release. But the release of aldosterone by the adrenal gland is also modulated by local hormones such as angiotensin II, but as well prostaglandins and many other factors. We tend to forget about the adrenal, perhaps because we're not endocrinologists, but if you look at the adrenal gland and look at the response to hyperkalemia, so if you bathe the adrenal gland in higher levels of potassium, you get a release of aldosterone, and that is strongly potentiated by increasing concentrations of angiotensin II. So why is that clinically relevant? Well, if you take rats and look at them and put them on angiotensin receptor blockers and ACE inhibitors, and then take out the adrenal gland and see how it responds to hyperkalemia, this is the normal response of the rat adrenal to hyperkalemia. And in the animals that were treated with an ACE inhibitor or an angiotensin receptor blocker, that is markedly blocked. So it's the adrenal response to hyperkalemia that also plays a role in hyperkalemia and hyporeninemic hypoaldosteronism and other disorders. The other issue is this concept that part of why you get hyporeninemic hypoaldosteronism is that your volume expanded. And there the mediator is probably ANP and BNP. This classic paper from Barbara Clark in the Epstein group at the BI looked at patients who had elderly patients that had hyporeninemic hypoaldosteronism. So they had lowish PRAs, they had lowish aldose, but they also had very high circulating ANP levels, suggesting that they were subclinically or clinically volume expanded. And that compared to patients that were older as well, but healthy, who had much lower levels of ANP. They then went and looked at these older patients, and if they infused potassium to induce a release of aldosterone from the adrenal gland, they compared these to young patients, the older patients to younger patients. The younger patients had a much greater adrenal release of aldosterone in response to hyperkalemia. If, however, they took the young patients and then they gave them ANP, they would blunt that adrenal release of aldosterone. ANP also blunts renin secretion by the juxtaglomerular cells. So this concept is that one of the circulating mediators that reduces renin release by the kidney, but also adrenal release of aldosterone, is circulating ANP. So the take-home messages in terms of the renin-angiotensin-aldosterone axis and hyperkalemia, that ANP, systemic and local RAS, and prostaglandins all affect renal renin release and adrenal aldosterone release. So think of the adrenal gland when next time you see a patient with this kind of hyperkalemia. And we talked about the role in hyporeninemic hypoaldosteronism of volume expansion and an increase in BNP and ANP. That this reduces renal renin release, but also adrenal aldosterone release. And this clearly relates to the evolving risk of hyperkalemia from combining multiple RAS inhibitors, for example, mineralocorticoid antagonists and ACE and congestive heart failure. Clearly, we don't do that quite as much as we used to, but clearly, the more you inhibit the renin-angiotensin axis, the more hyperkalemia you will see. So here's the first question that I have. You're referred a 17-year-old high school student for management of high blood pressure. He has not seen a physician since childhood, is on no medications. He denies drug abuse, including cocaine. His 50-year-old father is also hypertensive with a history of renal stones. Since you have your own private clinical research center, you admit the father and son for biochemical profiling while ingesting a diet with rigorously controlled salt content. This is actually from a case report. And when they looked at these patients, the son and the father, they both had this syndrome of hyperkalemic acidosis with low PRA and lowish aldo. And when they put them on, that was on a high salt diet, when they put them on a low salt diet, that entire syndrome melted away. So clearly now the PRA goes up and the aldosterone goes up and serum potassium goes down. So which of the following is the most appropriate therapy for this patient? aggressive K restriction, sodium restriction to 10 milliequivalents per day. Well, it seems to be successful. Nifedipine, amiloride, or hydrochlorothiazide. Any takers? It's clearly E. And this is one of these, this is actually a hybrid of this case report, but also a case question from the boards a while ago. So clearly you need to recognize that this is Gordon syndrome or type 2 pseudohypoaldosteronism or the hyperkalemic hypertension, however you want to call it. This is the mirror image of Gittleman syndrome, which is of course caused by loss of function in the thiazide-sensitive cotransporter. So in Gittleman's, you get relative hypotension, you get a hypokalemic alkalosis, and you get an increase in renin and aldosterone. You get hypocalciuria, that's part of our diagnostic criterion for littles, and they get they get high bone density because of the hypocalciuria. In Gordon's, you get hypertension, hyperkalemic acidosis, you have a suppressed renin and aldosterone, and you get hypercalciuria with nephrolithiasis. And this is responsive to thiazides. It's autosomal dominant transmission, rarely recessive, and there are 5 genes, of which 4 are now characterized. The real sort of breakthrough was many years ago now, when Rick Lifton's group showed that this was due to mutations in the Wink1 and Wink4 kinase. So these are called Wink kinases because they don't have catalytic lysine residue. So with no lysine, the K is the lysine. They don't have a catalytic lysine in the kinase center. And these are homologous proteins that have similar kinase domains, but also large signaling domains that control the activity of the kinases. Wink1 is expressed in the DCT cells that express NCC, the thiazide-sensitive cotransporter, and it's also expressed in principal cells that express aquaporin 2. And Wink4 has the same distribution in the distal nephron. You see it in principal cells, and you see it in the DCT cells. So there have been an enormous number of papers on the Wink kinases, more recently on the ubiquitination proteins that control activity of the Wink kinases. But the key issue is that Wink4, at least, and also Wink1, tend to downregulate activity of the thiazide-sensitive cotransporter, and that downregulation is abrogated by the mutations in the Wink kinase that are associated with Gordon syndrome. So really Gordon syndrome or Gittleman or familial hypertension with hyperkalemia is due to a profound activation of the thiazide-sensitive cotransporter in those patients. These patients are it's a very, very rare syndrome. Other than being able to pass your boards, the clinical relevance isn't enormous, but the physiology that we've learned from this is really important. And we now understand that there are downstream kinases that play a big role in regulating the thiazide-sensitive cotransporter and upstream and also in regulation in the setting of hyperkalemia. And it's tended to sort of underscore the role of the distal convoluted tubule in delivering sodium to the adjacent connecting tubule. And we now understand that regulating that thiazide-sensitive cotransporter is a big part of how we regulate K secretion. So again, if you increase salt transport in the DCT, you're not going to deliver as much sodium to the connecting tubule, and you won't excrete potassium. So this then becomes something that we can toggle up and down in response to potassium homeostasis. And this is reviewed in the Brenner and Rector chapter, but this aldosterone paradox where we integrate distal sodium and potassium transport. We now know that angiotensin 2 goes up in hypokalemia, that turns on NCC, reduces delivery to the adjacent connecting tubule, and so on. I won't go through all of this, but if you're interested, it's written up in Brenner and Rector and other sources very nicely. So if we switch to hypokalemia and think about the causes, again, there's artifactual pseudohypokalemia due to leukocytosis, for example, with an uptake of potassium by white cells, as you see in AML. There's redistribution that can cause hypokalemia. Insulinopenia in DKA will do this. Beta-2 agonists, sympathomimetics, theophylline. Alan showed a case of hypokalemic periodic paralysis earlier. You also get non-renal loss where you lose potassium in the skin or stomach and by suctioning. and the intestine through laxatives and diarrhea. So here, question number 2, you're asked to evaluate a female patient with intestinal pseudoobstruction, otherwise known as Ogilvie syndrome, with diarrhea and profound hypokalemia. The meds include metoprolol, risperidone, and insulin. Imaging and exam is notable for signs of colonic distension. They're hypernatremic with a potassium of 2.5 and metabolic acidosis, a TTKG of 3 with stool potassium of 100 and stool sodium of 10. So which of the following is the most likely cause of this patient's hypokalemia? Ischemic bowel, C. diff colitis, activation of colonic K secretion, osmotic diarrhea, or sympathetic activation with redistributive hypokalemia? Well, the key here is urine TTKG is appropriately low, so that the loss of the potassium here is not in the kidney. But we're told that the stool potassium is 100. I don't know about you, I'm not really sure what the normal stool potassium should be, but that's a pretty high to my understanding. So clearly this patient had a relatively potassium-rich stool. So just from first principles, this seems like this is activation of colonic K secretion. And indeed it is. This was now maybe 8 years ago that some of the first reports came out of Ogilvie syndrome with hypokalemia, where they have this massive increase in intestinal colonic BK channel expression. One patient who had concomitant ESRD, they had this immunochemistry showing massive upregulation of BK. And it's known that BK channels are turned on by catecholamines, and catecholamines are stimulated in Ogilvie syndrome, and it's thought that that plays a big role. So this is one of those cases from actually now more than 10 years ago, where the patient had Ogilvie syndrome, and when they did staining with BK, they saw this enormous upregulation of BK channels compared to the normal colon, where it was only in the sort of at the apex of the crypt. In terms of renal loss and hypokalemia, clearly drugs such as diuretics play a big role. I want to underline the role of magnesium deficiency. There are many mechanisms for how magnesium deficiency causes hypokalemia. One is inhibition of the muscle NAK-ATPase, so you lose potassium from the muscle and then excrete it. But the really interesting thing is magnesium blocks ROMK channel from the inside of the cell. So if you have lower levels of magnesium inside the cell, in the collecting duct and in principal cells in the connecting tubule, you get inappropriate activity of ROMK and you have excessive K leakage in principal cells. In tubular damage, either classically from cisplatin and other forms of ATN, and then we've talked about some of these intrinsic renal transport defects, such as Little syndrome, Barter's, and Gittleman's, and also hereditary distal renal tubular acidosis, where you get hypokalemia. I want to talk a little bit about hypokalemia and hypertension. Commonly, this is aldosterone-producing adenoma or bilateral adrenal hyperplasia. Alan went through some of the less common causes that you need to think of, particularly for the boards. One of the very interesting developments, though, in the last 10 years has been a greater understanding of the physiology of how the adrenal gland responds to potassium to release aldosterone. So there are the angiotensin II receptor turns on or inhibits actually these apical K channels that sense potassium, ultimately increases in intracellular calcium, turn on the enzyme, the aldosynthase that makes aldosterone. In GRA, you have a hybrid gene between that gene and one of the cortisol-producing enzymes. So you get the aldosynthase that is now under the control of ACTH and under the control of glucocorticoids. So if these patients have high levels of glucocorticoids, you turn off this syndrome, hence the word glucocorticoid remedial hyperaldosteronism. More commonly, though, in adrenal adenomas, there are these loss of function mutations in many of what are called now aldo driver genes, such as this apical K channel and some of these voltage-gated calcium channels and sodium ATPase and calcium ATPases. The final common pathway is you have an increase in intracellular calcium in these adenomas, and that's what turns on the gland and turns on the aldosterone release. And there's a lot of really interesting pathophysiology that's now emerged in these patients with hyperaldosteronism. We'll talk a bit about it at lunch in a particular case. In terms of the screening and confirmatory testing in primary hyperaldo, you need to check up an aldo to renin ratio. You need to check when they're normal kalemic, because if you're checking when they have a low potassium, aldo will be appropriately suppressed, albeit higher than you would otherwise expect because of the low potassium. You also need to be aware of the drug effects, either ACE and ARB. There's a whole list of drugs that are appropriate for testing. They include drugs such as verapamil. Other calcium channel blockers affect renin-angiotensin signaling. Hydralazine is relatively neutral. Alpha blockers are neutral. And you can also use amiloride. So those 4 or 5 different drugs are what you need to put these patients on and take them off the ACE inhibitors and the ARBs and the mineralocorticoid antagonists when you evaluate them for hyperaldosteronism. If you then do a 24-hour urine aldo and confirm that it's above 12 micrograms per day, then you need to do salt suppression testing, either oral or look at their aldo to PRA ratio after sodium chloride infusion in an infusion unit. Then you need to go to imaging and adrenal vein sampling to look for which gland is overactive. If you do a CAT scan and you see an adrenal adenoma on one side, that doesn't mean that that's the culprit adenoma all the time. Some of those patients, it's actually the other adrenal gland that is the culprit gland, which is why you then need to do adrenal vein sampling and avoid taking out the wrong adrenal gland. So again, this goes through how you do adrenal vein sampling and how you decide which gland to operate on. If we then now talk about the consequences of hyperkalemia, and we'll talk about the consequences of hypokalemia, the major consequences and effect on excitable tissues with a change in resting membrane potential. In the heart, that leads to decreased myocardial conduction velocity, an increase in the PR and QRS, an increased rate of repolarization that give you the T-wave changes. In the skeletal muscle, you see weakness, fatigue, and paralysis. In the kidney, you also get a decreased ability to secrete ammonium, causing acidosis. So this is the usual progression of T-wave changes and QRS and P-wave changes that we see. Just remember that progression doesn't always occur. There's the old saw, the first symptom of hyperkalemia is death. It's a little morbid, but it does underline that fact. These ECD changes are not sensitive, particularly in ESRD. You can see peak Ts in other disorders. And you can get atypical ECGs, particularly the Brugada sign, the pseudo-ARB right bundle branch block with what's called a coved SE segment. You can also see pseudo-infarction patterns in hyperkalemia. So just be aware that there are many different patterns of ECG changes that you can see in hyperkalemia. I think you're all familiar with the treatment of hyperkalemia, giving calcium gluconate to stabilize the membrane potential, giving insulin or beta-2 agonists to increase cellular potassium uptake, and doing K removal with potassium binders and with hemodialysis. Remember that hypertonic slugs of bicarbonate are not effective. This was a figure from many, many years ago. And this led to reducing the use of these hypertonic slugs of bicarbonate in the typical response to hyperkalemia. Part of that is because you're affecting pH, but you're also giving a hypertonic stimulus, and those two probably balance out. If, however, you give people isotonic bicarb over several hours, you will see a drop in serum potassium. So these are dialysis patients that were slightly acidemic, that were given bicarb over 6 hours, and you can see a nice drop in their serum potassium over that period of time. In terms of insulin and glucose, the problem here is really balancing the hypokalemic effect with the hypoglycemic effect. And if you give 10 units of insulin with 25 grams of 50% dextrose, approximately 20% of those patients will become hypoglycemic. So you really need to give them D10 as an infusion afterwards. Some people will give lower amounts of insulin or higher amounts of D5, D50. Whatever you do, you need to be aware of balancing that effect, the hypokalemic effect of the insulin with the hypoglycemic effect. In hyperglycemic patients, you can give insulin alone, but you should never give D50 on its own because the hypertonic effect can predominate acutely, and that is what can cause the demise of the patient because of sudden hyperkalemia before they have a chance to have the pancreas respond. Beta-2 agonists, remember that it's 10 to 20 milligrams of nebulized albuterol, so about 2 to 4 times the usual amount of albuterol that we use for asthma. It's synergistic with insulin. The concern is the reflex tachycardia in somebody that may have a weak heart or may have some degree of underlying coronary disease. So for many years now, we've talked about the risk of intestinal necrosis with Kayexalate. The FDA put out an advisory 10 years ago. Many people would stand up and scream that they'd used Kayexalate for decades. They'd never seen this, but this really does occur. This was a case we had at the VA a few years ago where a patient was given 2 doses of Kayexalate, then developed abdominal compartment syndrome. Had I not asked the pathologist to look for Kayexalate crystals in the bowel, we would have attributed the intestinal necrosis to the abdominal compartment syndrome rather than to the Kayexalate that the patient was given. So Kayexalate has a very slow onset effect. So usually, if it takes 6 to 8 hours for Kayexalate to have an effect, by that time you should have had the dialysis set up or a dialysis nurse come in to do dialysis. It's not restricted. This intestinal necrosis, which is typically fatal, is not restricted to the post-op setting. And it can also occur in the absence of giving sorbitol. So it's the Kayexalate, it's not the sorbitol. The key thing is that now we have available alternatives. We have Patiromer and we have ZS9 or Lokelma as it's called. So Patiromer, the chief adverse event is hypomagnesemia. There's a 4.3% incidence of magnesium in the Amethyst trial. My clinical experience has been it's an issue in the patients that I give it to. I typically give it to patients with diabetic nephropathy. There's a large, significant association between type 2 diabetes and the risk of hypomagnesemia. So you will often see the hypomagnesemia. There's some concerns with drug interactions. That's only been documented for ciprofloxacin, metformin, and thyroxine. You can obviate that if you dose 3 hours between or before other drugs. That gets a little complicated for patients, however. It is demonstrated to reduce circulating aldosterone, and I wonder if that may play a role in reducing what's called aldosterone breakthrough, that increase in aldosterone that we see many months after starting an angiotensin receptor blocker or an ACE inhibitor. So sodium zirconium cyclosilicate, or ZS9, or now the brand name is Lokelma. It's selective for potassium and ammonium. It does not bind to magnesium or calcium, so you don't get the hypomagnesemia that you see with Patiromer. There's an associated increase in serum bicarbonate, which may be advantageous in our patients with chronic kidney disease. There are no drug interactions, and it has a rapid onset. After one 10-gram dose, the serum goes down, potassium goes down by 0.4 at 1 hour, by 0.6 at 2 hours, and by 0.7 at 6 hours. It may contribute to edema because there's a sodium exchange, presumably due to that sodium load. However, many of the patients that we give these drugs to, Patiromer and Lokelma, they're also predisposed to edema, so the true contribution of Lokelma to edema isn't entirely clear. As of about a month ago, there was, I don't know if it's actually in the edition of Jason, there's the trial, the dialyzed trial of Lokelma in patients with pre-dialysis hypokalemia. The bottom line is that they saw a nice reduction in pre-dialysis potassium in the patients that were given Lokelma. And this is a short trial. It was, I think, 4 months or a few months. It's not really clear what the long-term consequences would be. But there's a lot of interest in trying to reduce pre-dialysis hyperkalemia in our dialysis patients, given the association with mortality in having a high potassium, but also a high gradient between the dialysis sodium, potassium and the serum potassium. So I'll go through one other issue in terms of treating with dialysis is the serum dialysis gradient. So dialysates with a lower K concentration are more effective but can lead to rebound hypertension. They also have a high risk of arrhythmia, and there's this epidemiological association in outpatient dialysis units between 1K and 0K baths and mortality. I find that a graded reduction in potassium concentration is effective, and that's sort of our standard of care at the Brigham. So if somebody comes in with a K of 8 with EKG changes, we do not start them on a 1K bath, we'll start them on a 4K bath and sequentially reduce that. And it's very clear in many studies from a group in Italy that if you have a constant gradient between the serum and the dialysate potassium, that's associated with less arrhythmia. In terms of hypokalemia, the one consequence that I want to underline is the risk of hypertension, also the risk of arrhythmia. Hypokalemia clearly prolongs the QT interval. This is a case report where the patient was hypokalemic with a prolonged QT. As the potassium came up, the QT interval reduced. Also remember the deficit of potassium in hypokalemia. This is a paper from Rick Stearns many years ago that correlated the whole body potassium deficit with the serum potassium. It's actually quite a linear relationship, as you can see. So for every drop in potassium of a 0.27 milliequivalents, that's a 100 milliequivalent deficit for the patient. Clearly, that's not a very accurate calculation, but it's very important to underline to our colleagues that a potassium of 2.5 compared to a K, correcting that patient to a K of 4, that may be a deficit of 600 milliequivalents or thereabouts. And that needs to be corrected over a period of time. And if you don't correct it, that patient's going to become hypokalemic again. So we look for sequelae when we treat hypokalemia. We look for weakness. They need to be on a telemetry monitor, particularly if they have a prolonged QT. We need to replete magnesium first. Remember, I talked about the effect of magnesium on ROMK and also the muscle NAKPase. Oral therapy is preferred, particularly KCL. And you replete that deficit sequentially over days. Clearly, if you gave a patient 600 milliequivalents in one fell swoop, you'd kill them. It takes a period of time for that muscle to be taken up by for that potassium to be taken up by the muscle and to gradually replete the potassium deficit. In terms of intravenous infusions, you can give that safely up at 10 milliequivalents an hour, but higher rates need to be in an ICU and probably through a central line. There's a debate whether a femoral line is better because it's not as close to the heart. I think that's mostly opinion-based. You should not, however, use dextrose solutions. It's well described that if you give KN dextrose, you get an acute hypokalemia due to the insulin release, and that can actually precipitate death because of an arrhythmia. So this is a case of thyrotoxic periodic paralysis. Just remember that we now understand in Asians and patients of Asian and Hispanic origin what the genetic defects are that predispose them to thyrotoxic paralysis. So there's a muscle-specific inward K rectifying channel that has point mutations in it. And there's a related channel that also in genome-wide association studies seems to predispose to hypokalemic paralysis. And as Alan mentioned in his case, the use of the TTKG or K to creatinine ratio, this is one setting where you actually want to know that in the emergency room, because the patients that have hypokalemic periodic paralysis, in this case they were all thyrotoxic patients, they had very low TTKGs and very low K creatinines compared to the patients that had weakness with K wasting who had inappropriately high TTKGs. So why is that clinically relevant? Well, it's well described that if you see a patient with thyrotoxic periodic paralysis, they may be weak, they may need treatment, but that treatment has a risk of rebound hyperkalemia. And that rebound hyperkalemia can in and of itself be fatal. There are many other disorders where you get this uptake in muscle, particularly patients with acute cerebral edema and acute cerebral injury, where you also get that huge sympathetic activation that causes hypokalemia. Well, the rationale then becomes to give these patients high-dose propranolol, because a lot of the effects of thyroid hormone are actually mediated through turning on beta-2 and beta-1 receptors and turning on the NAK-ATPase. So if you give these patients high-dose propranolol, you can safely get their potassium up, and you also see an increase in their phosphate and magnesium that'll also be low, and you won't have that risk of rebound hypertension. So in terms of take-home messages for the entire talk, we talked about regulation of renal renin release and adrenal aldosterone release. We talked a little bit about the aldosterone paradox, that aldo is not the sine qua non for potassium regulation. We talked a little bit about new developments in hyperaldosteronism and thyrotoxic periodic paralysis. We talked about treatment issues in hypokalemia and the role of new K binders in hyperkalemia. Some of these references here, the Brennan Rector chapter and the Harrison's chapters, and also I write the K cards for up to date, and all of these issues are well described in those references. Thank you.